Episode of Tell Me in 10. Today we're going to review the imaging of the non-arthritic hip. This will be an MRI based talk, and we will talk primarily about the intra-articular issues in imaging the non-arthritic hip. So if we think about non-arthritic hip pathology, we can break it up into two parts, intra-articular and extra-articular. Today we will deal with the intra-articular components. And here we'll talk about the bone, the labrum, the ligamentum teres, and cartilage. So this is what we're going to focus today's talk on. The first thing that we do when we look at patients who have hip pain is we look for the presence of bone marrow edema. And when we see bone marrow edema, the things we try to do are differentiate what the cause of bone marrow edema is. If we consider something like avascular necrosis, that would usually present as something with bone marrow edema and a serpiginous low signal band, such as we have here. In a more chronic case, you would see a very discrete band which is bright signal, and you would not see a lot of bone marrow edema around it. So this is the acute one, and this is the more chronic one. The acute one we're particularly interested in because this is the one that has the potential to progression to avascular necrosis. The chronic one is one that has gone into a more of a stage of healing. The other common finding that we will see in patients with bone marrow edema is you will notice that the bone marrow edema almost radiates from this central point over here. And when you look carefully at this area, you'll see a low signal band, which is essentially what we call a subchondral insufficiency fracture. Now, this is an entity that was previously known as transient osteoporosis or spontaneous osteonecrosis. When it progressed to rapid osteoarthritis, they called it spontaneous osteonecrosis. And when it recovered on its own, they called it transient osteoporosis. Today, it's fairly clear to everybody that this is an entity called a subchondral insufficiency fracture, which could spontaneously heal to become normal, or which could progress to rapidly progressive osteoarthritis because of the collapse. Other causes of bone marrow edema that one should always be aware of, such as in this case with acetabular bone marrow edema, what you see is along with that, there is fusion of the sacroiliac joints here, and this is a patient with ankylosing spondylitis, so inflammatory arthropathies. Another thing that you may occasionally see with bone marrow edema along the posterior aspect of the femoral head, and along with that edema in the posterior capsule, and this you can see impactional bone marrow edema in somebody who's had a posterior dislocation. You may see bone marrow edema along the femoral neck, and this is a common location for stress fractures, so think about that carefully. Now also remember that sometimes when it goes down to the neck, there may be a subtle osteoid osteoma, and that's something that you should be on the lookout for. Once you've looked at bone marrow edema, the next thing we tend to focus our attention on is the acetabular and femoral head geometry. And here essentially we say that the acetabular head has got a small little divot here, which allows it to move conveniently within the acetabular cup. If there is bony overgrowth along the anterior aspect of the femoral head here, then this can lead to impingement against the anterior acetabulum, and this leads to what is called cam-type femoroacetabulum impingement. Consequently, you may have a situation where the acetabulum is overgrown anteriorly, or the acetabular cup has deepened significantly, and because of this, the femoral head sits far deeper inside this, and there is a likelihood of the femoral head impinging both anteriorly as well as posteriorly, and this is known as pincer type femoroacetabular impingement. In some situations, you may have both the femoral sided problem as well as the acetabular sided problem, and this is called a mixed morphology. Here's what a cam type femoroacetabular impingement looks like. If we follow this femoral head here, you'll see that there is a normal contour of the femoral head curving down, whereas if we look at this femoral head here, the curve down is much less. So you don't have this more S-shaped appearance, but instead you have a more flatter curve-shaped appearance. And this is the bump that we're looking for cam-type femoroacetabular impingement. You can see this on an MRI as well, when you can see this head is curving down, and this head here is definitely much straighter. So this again is cam-type femoroacetabular impingement. Another way that we look for cam-type femoroacetabular impingement is we look at a line that runs along the axis of the femoral head-neck junction. We get an image like this on the axial plane or an oblique axial plane. We draw a circle that goes around the entire femoral head, a best fit circle, And then we draw an angle that goes from the greater trochanter to the center of the femoral head, as well as to the point where the femoral head and the circle do not meet each other. So this is the point where they depart from each other, and we draw this angle. And this angle is known as the alpha angle. And the alpha angle, if it is greater than 55 degrees, it is indicative of a CAM type morphology. And I'm going to take out this term FAI from here and just say CAM morphology, and I'll explain why that in a little bit. What happens because of the CAM type morphology is you have impingement of the anterior femoral head against the anterior acetabulum, as a result of which there is a tear or a degenerative tear in the anterior superior labrum, and subsequently there is articular cartilage loss over the anterior superior aspect of the hip joint. In pincer type femoral acetabular impingement, what you may see is abnormal version. In other words, the acetabular cup rotates more to face more anterior or to face actually more posterior. And when you have this more posteriorly facing cup, there's obviously a greater chance of impingement both anteriorly and posteriorly. This is typically demonstrated on the radiographs by something called a crossover sign. So here you can see this is the margin of the acetabulum anteriorly as well as posteriorly. And when you can see that these two areas cross in the middle right here, then that is called a crossover sign. Normally they would cross towards the top. So the crossover sign is something that indicates to you that there is abnormal version of the acetabulum, and that could predispose somebody to pincer type FAI. So here you can see this. Sometimes you can just see a big acetabular spur or a bump over here, and that could predispose somebody to a to a pincer type FAI. And alternatively, you could just see central migration of the hip, so the femoral head just goes deeper into the acetabulum, something called protrusio, and that could lead to a pincer type FAI. Okay, and pincer type FAI patients will typically present with posterior labral lesions. So if we think about the spectrum of the morphology of femoral acetabular impingement, you could have a normal hip. You could have somebody who's got a big bump here, which is a femoral sided bump, which is a CAM lesion. You could have acetabular overgrowth, which is going to be something which a pincer type one. And then here you could have both, where you have the acetabular change as well as the femoral head change. And then this would be a mixed type of femoral acetabular impingement. So just ignore this image for now. Okay, but what does all of this mean? We did a study in Indian patients where we looked at the radiographic abnormalities or the findings that would indicate the presence or absence of a bump, or that would indicate that there is an abnormal version of the acetabulum. And what we found was that there was a pretty high incidence of these abnormalities in patients who were completely asymptomatic. So previously the theory was that all these patients should get surgery and aggressive intervention, but now we're finding that this anatomy exists in many people who are asymptomatic, and we should not be really operating on all these patients just on the basis of their imaging abnormalities. And so they came up with something called a Warwick agreement, and based on this, the most important thing they said is that FAI is not an image-based diagnosis. You must have signs and symptoms as well as imaging to call somebody FAI. The asymptomatic patients do not usually require surgery, and the treatment may be conservative or surgical based on the signs, symptoms, and imaging. So usually many people improve, untreated patients can worsen, and we don't know if this is really true, that surgical intervention will reduce the likelihood of early osteoarthritis. So femoral acetabular impingement, very important thing to remember, that this is an entity that can often be overcalled, and it's important that you have a clinical entity along with the imaging findings before you label somebody as a patient with femoral acetabular impingement. Now moving from the osteostructures to the labrum, it's important for you to remember that we can see the anterior labrum really nicely as this triangular beak-like structure. And here it is. And for those of you who can't remember what a beak is, just draw a bird around it, and that's what it is. So a nice black beak would indicate that this is a normal labrum. Sometimes we can see a little bit of fissuring in this labrum. So like in this one, you can see this little bright signal inside it, but it doesn't go through and through. And so that would indicate an intra-substance tear. Sometimes you can see just a prominent but very slender finding, which area of high signal, which would indicate a cleft. Sometimes you can see a broader, more fluid-filled finding, which would indicate a more discrete tear. And sometimes you can see a small little globular area adjacent to it, which is essentially a paralabral cyst. And when you have a paralabral cyst, it's usually a pretty good indicator that somebody has a labral tear. So this is how we can evaluate the different signals within the anterior labrum. The posterior labrum similarly can have a cleft, can have a more discrete tear going through and through like this one does, and you can have a paralabral cyst forming with it. After the labrum, the next thing we move our attention to is the ligamentum teres. The ligamentum teres is essentially a band of tissue that extends from the inferior sort of defect in the labrum to the center of the fovea. And this is the ligamentum teres here. And it has an anterior and posterior band, so you can see it over here as this little triangular structure. And it is by some people considered to be the ACL of the hip. So it's kind of important, and we have seen patients who have problems because of tears or degeneration or abnormalities in the ligamentum teres. What are the abnormalities? So let's see, this is the normal ligamentum teres, this little band of tissue coming out from the fovea like this and going down. And this is it in its mid substance here, going down, and you'll find ultimately it goes all the way down to the inferior aspect of the acetabulum. So here is the normal labrum again. Normal ligamentum teres again. What can happen to this? Here's your normal ligamentum teres. Here is a thickened ligamentum teres with high signal in it. So there's intrasubstance degeneration. As with all other ligaments and tendons, when there's intrasubstance degeneration, you can predispose yourself to the formation of intraosseous cystic change. And this is an example of somebody where you can see that there is a defect or there is nothing filling this gap. There's a hole in here. There is no ligamentum teres tissue, and this is essentially a foveal tear of the ligamentum teres. This becomes typically more important in patients who have an underlying hip dysplasia because they have less bony support and therefore their hip tends to be more unstable. After we look at the ligamentum teres, we turn our attention to the cartilage. If you do good high resolution imaging, you will see the articular cartilage very nicely on both the acetabular and the femoral side. So here is the acetabular bone, here is the femoral bone, and between these two, this gray area is a combination of cartilage of both the femoral and acetabular cartilage. And you can see that it's gray here and all this way here, and gray here and all this way here, and this is the femoral and acetabular cartilage. And you can see quite beautifully how this posterior femoral head articular cartilage is actually missing, and this is a posterior femoral head articular cartilage lesion. So what we've tried to do in this section is talk about non-arthritic hip pathology. We've talked about the bones and the common causes of bone marrow edema. We've talked about femoroacetabular impingement and how it is a clinical entity, and so imaging findings along with clinical findings clinch the diagnosis, not just imaging findings. We've talked about the labrum, the presence of a cleft, a discrete tear, and the importance of a paralabral cyst. We've talked about the ligamentum teres and looked through everything from a normal one to then with degeneration and one with a tear. And we've talked about articular cartilage and how we can see it really nicely to see focal chondral lesions. So with that, we'll stop this section on non-arthritic hip pathology, the intra-articular lesions, and the next session we'll talk about the extra-articular lesions. Thank you.